Hello and welcome to ET Health World. I am Rashmi Mabian and today we have with us Dr. Krishnan Ganapathy, member of the Board of Directors of Apollo Telemedicine Networking Foundation and Apollo Telehealth Services, former President Telemedicine Society of India and Neurological Society of India. He is the Honorary Distinguished Professor at the Tamil Nadu Dr. MGR Medical University, Chennai. Thank you for joining us, Dr. Ganapathy.
Thank you, Rashmi.
So, from the start of COVID pandemic, telemedicine has been a boon for general public to resolve their healthcare issues through online doctor consultations taking place over modes like phone calls, video calls, or chat. Today, in this conversation with Dr. Ganapathy, we will understand that in over 1 year since the pandemic began, how has been the acceptance towards telemedicine? So my first question to you, Dr. Ganapathy, is, being a pioneer in the field, could you tell us about the penetration of telemedicine in India up until the COVID era?
Well, it'll be difficult for people in 2021 to understand how we started telemedicine in 1999-2000. It was in March 24, 2000 that Bill Clinton formally commissioned the world's first VSAT-enabled village hospital in Aragonda, the birthplace of Dr. Pratap Reddy, the founder chairman of the Apollo Group. The first 10 years I spent in just talking about telemedicine. Telemedicine was a dirty word at that time. Everybody laughed, ridiculed, nobody would accept it, and a lot of evangelization had to be done. Slowly, people understood, and with better information and communication technology, we started convincing people that telemedicine is the way modern healthcare will be about. About 5 years ago, we started the first public-private partnership with the government of Himachal Pradesh. We started the world's first 24/7 tele-emergency services in the Himalayas at a height of 14,500 feet. Our phenomenal success by delivering remote healthcare at minus 25 degrees temperature, 5 months in a year, snowstorm, landslides, etc., convinced other governments that public-private partnership is the way to go. Starting with this success, people realize that telemedicine is definitely an entity to be really seriously thought of. However, we were knocking at the doors of everybody. The Telemedicine Society of India was literally begging the Ministry of Health, the Ministry of Law, etc., to legalize telemedicine, to pass regulations, etc. One strand of RNA changed the entire picture, not only in India, but in the entire planet. I often call the coronavirus as the Global Chief Transformation Officer. It made possible what we would never, ever have expected in our wildest dreams. You are absolutely right. Today, remote healthcare or I don't like the word telemedicine, incidentally. I prefer the word telehealth. Medicine implies a doctor-patient face-to-face single-person encounter. We are now talking of health. We would like to use information and communication technology to promote wellness, to make people healthy. I would be the happiest person if the number of footfalls coming to a hospital significantly reduced. In other words, today, the emphasis is on the doctor visiting your home. When I started my medical career 53 years ago, we used to have house visits. Today, we are reviving house visits. The only difference is it is electronic house visits. A hospital in your pocket, a laboratory in your pocket. These were all our dreams, but now these dreams have been translated into reality thanks to the lockdown, where people were enforced, thanks to travel restrictions and so on. Today, even after the pandemic is denotified, people have accepted telemedicine as a part of their way, and I'm confident that in the years to come, remote healthcare will eventually, perhaps even in my lifetime, replace physical visits.
Thank you so much, Dr. Ganapathy, for giving us that amazing flashback. So on March 25th last year, the government of India notified the telemedicine practice guidelines. Do you feel that this was a good impetus for adoption of change?
Absolutely. This made all the difference. We had thousands of doctors on the borderline, There were several doctors, a few hundreds of them, people like me, passionate, enthusiastic, who didn't bother too much about rules and regulations. But there were thousands of doctors who were unwilling to give a teleconsultation when the picture was still not clear. Though there was no law saying that telemedicine is illegal, neither was there a ruling that telemedicine can be done. So I think this made all the difference. And of course, we have a long way to go. The Constitution of India has been amended so many times. Similarly, I'm sure there will be a 2.0, a 3.0, there will be modification. The most difficult thing, not only in India, but all over the world, the law can never, ever keep up with technology. And what is not considered today will be a part of our routine lives. So I really hope that the authorities will consider and taking into account the views of all the experts, the stakeholders, and very soon issue a second modification, because we have learned so much in the last 15 months in the real world experience. So far, our knowledge of e-prescription, our knowledge of group therapy, our knowledge of so many things was more theoretical, and we were extrapolating what was happening in Western countries. Today, we have picked up enormous knowledge in the last 15 months, and I do hope the authorities will consider issuing a revised version at least next year.
And what are the modifications that you're keenly looking at?
See, one of the things is prescription of drugs. Quite rightly, several drugs have actually been banned. The regulations prohibit us from prescribing several drugs. But we need to relook at this. There is no point in a doctor making a brilliant diagnosis and making a diagnosis unless he is able to treat the patient. And for that, we need to understand that generic drugs are very important. So that is one, the e-prescription part of it. Again, the present guidelines are totally silent on whether a doctor can give an RMP, as the word is used, registered medical practitioner in the Medical Council of India or one of the state medical councils. The regulations are totally silent on whether I can give a consultation to a patient living outside India. So overseas consultations, I still do not know whether it is legal or illegal. So like this, there are many aspects. Artificial intelligence. More and more, we are using artificial intelligence in healthcare. Automated self-dispensing kiosks. We today have kiosks which dispense medicines. So all this technology, we have to keep up with technology.
Great, sir. So execution of telemedicine is, of course, heavily dependent on good bandwidth. Do you feel that this continues to be a major bottleneck for its uptake across India even now?
Yes. When I started telemedicine, we were using 64 kbps. I think the present people don't even know what is kbps. My grandson certainly doesn't know what is kbps because he is accustomed to 5 and 10 mbps from the time he was born. So the world has changed completely and India has changed. They're absolutely delighted. The rural teledensity in India has become an unbelievable 75% is a rural teledensity in India. And I'm very sure that 5G, of course, the pandemic has delayed it, but already it has started. Maybe in another year to 2 years, we will be seeing 5G in healthcare. So bandwidth, you're absolutely right. Well, let me put it this way. Bandwidth is if I want to achieve CNN quality or BBC quality. But as a medical doctor, I don't necessarily require the best bandwidth. I only want enough bandwidth to ensure that I do not make a mistake when interpreting an audio or a video. And this 5 Mbps should be enough, though all of us would like to have 100 Mbps, 200 Mbps, etc. But this is getting available in more and more places. There are audio drops, there are video drops, but I think the progress has been absolutely phenomenal. And if anybody today blames the lack of bandwidth as a major reason for not doing telemedicine, I would take it with a pinch of salt.
And when you speak about the possibilities that 5G is going to bring, could you just elaborate on that?
Of course, 5G is more for quaternary healthcare. It is really not going to make too much of a difference so far as ordinary consultations are concerned. I am talking of surgical mentoring, for example. We have super specialists, subspecialists in the national institutes and in the quaternary care hospitals in the metros. Now, we need to train the next generation of surgeons. Everybody can't come to Delhi and Madras for treatment. So 5G will be tremendously helpful in hand holding, where an experienced senior surgeon will be in real time, will actually be able to see exactly the dissection which a surgeon in a tier 2 or tier 3 city is carrying on and hold him. So telementoring, not telesurgery. People confuse this with telesurgery. I really am not too much fascinated by telesurgery, excepting it is more to demonstrate that it is technically feasible. But robotic surgery at the other end, when you have a person with white hair, at the end of the day, white hair still is important. So somebody who has done 500 procedures, he will be able to guide somebody who has done 5 procedures or 10 procedures in real time. So this will make a tremendous difference.
So, as we talk about telemedicine, we need to also focus on what the doctors feel and how they experience telemedicine. And coming to understanding doctors' experience, what are the common challenges that they find in providing teleconsultations?
Challenges are many. I could divide the challenges as challenges which can be corrected by the doctor himself, which I think is a major component. Challenges where the patient at the other end needs to be educated. Challenges in technical challenges, information and communication, like you mentioned about bandwidth. Now, telemedicine is not video conferencing, not in 2021, definitely not in 2021. The public and maybe some of the authorities and doctors think that telemedicine is an extension of a telephone call and is video conferencing. No, not at all. Telemedicine, the practice of telemedicine is just like, I would put it as equal to a Hollywood movie, a Hollywood blockbuster. I mean, you know the amount of things which go in before a film is shot. Similarly, body language is very critical. I strongly believe that if the telemedicine movement, like a Quit India movement, if the telemedicine movement is going to achieve that critical mass, essential for a successful takeoff, you blast into outer space. If you want that, the patient experience, as I call it, is the most critical thing. So body language is very, very critical. There is a fear among many patients that telemedicine technology is dehumanizing medicine. The personal touch is totally lost. I mean, you can't send an SMS or an email, or you just can't tell in 20 seconds, you can't tell a patient, look, you've got a brain tumor and you need to be operated immediately. He has got 150 questions to ask. I should be able to answer those questions. So my plea before the medical audience, if there are any listening to this program, my plea to them is body language, body language, body language. Make the patient feel that you are empathizing with him, you are sympathizing with him, eye contact, listen to him, hear. I mean, EMR is fantastic. Hospital information systems are terrific, but that is not. A doctor with all the technology in the world must still practice tender, loving care. TLC. I strongly believe what Lars Lexel, the inventor of the Gamma knife, then the world's most technologically advanced equipment, he said, I quote, a fool with a tool is still a fool. Telemedicine is a means to achieve an end. It is not an end by itself. Technology can never, ever, should never, ever replace an empathizing, sympathizing doctor. So I think this is a great challenge. See, after my consultation is over, the patient should say, wow, I didn't see any difference at all. It was almost as if the doctor was in front of me and touching me. So don't look at your watch and do a teleconsultation. Don't be looking at your phone and attending to WhatsApp messages and something else while the patient is on the screen. Entire undivided attention to the patient. That is number one. So far as the patients are concerned, they need to be educated. They need to be told that, look, technology is beyond the doctor's control. There could be an audio drop. There could be a video drop. And most important, I expect my doctor to have the maturity to call off for teleconsultation, not stand on ego. In the olden days, there are at least 5% of times I would say, sorry, I'm just not happy with the quality of the MRI and the CT which I'm seeing. I cannot give an opinion. You have to come here physically. Or you send a CD in the olden days by courier, etc. So we expect the doctor to have the maturity to call off a teleconsultation. Number three, teleconsultation cannot, should not, will not replace a face-to-face consultation all the time. Most of the teleconsultations which we do are review consultations. So in other words, first at least a patient has come. The advantage of telemedicine is we can do a very sophisticated tele-triage. I can prevent unnecessary movement of patients from a town or a tier 2, tier 3 city to a big quaternary care center. So there are so many challenges. The other challenges, I've never been a diplomat in my life, and we are all hypocrites at times. I think we need to talk about reality. We have heard of Wi-Fi, we have heard of WiMAX. How many of you have heard of YFM? This is a term which I've been using for the last 2 decades. WIIFM. What is in it for me? Finally, any technology, if it is to take off, every single stakeholder in the ecosystem should benefit out of it. The benefit may be monetary, the benefit may be some other way. There has to be a return on investment. Now, in the last 6 months, last 1 year, thanks to digital methods of payment, thanks to Google Pay, for example, I'm just giving an example, Paytm, that, this, etc. You people know much better than me. Payment is extremely simple. So at the end of the day, you cannot expect a doctor. Yes, all of us give free consultations. We are very happy to do this, etc. But then this cannot be 100% of the time. So there has to be a remunerative method. There has to be a carrot. There has to be a stick. Though I would not like to use a stick, I would like to use a carrot. You must make champions. Unless you have doctor champions in every single department, in every single hospital, telemedicine will never flourish. And also the political will, which I think is a tremendous difference in the last 6 months. No less a person than the Prime Minister of India has mentioned telemedicine, telemedicine, telemedicine every time he addresses the nation concerning COVID. Every state government today has telemedicine officers. There are nodal officers, 539 medical colleges in India. I think a majority of them have. We have a long, long way to go, but we are certainly there. And I'm extremely excited that the government is talking of telemedicine. And I dream of the day when the next election, the last few elections, people have been giving laptops, people have been giving mixie, grinder, that, this, etc. I dream of the day when a person standing for an election, both for the assembly and the parliament, says, you elect me and I will ensure that my entire district has got telemedicine units in every single primary health center, community health center, district hospital, etc. This is the day we want. And once the members of the assembly and the parliament advocate and they say, we will provide you with telemedicine, that day telemedicine will take off completely.
So since you talked about optimism, we did see a lot of doctors taking up telemedicine, especially during the COVID era. And I am very optimistic that this will continue. So what is your message to the doctors who are still considering, still thinking about coming onto the telemedicine platform to provide consultations? The mindset that has still not changed.
Okay. My message is, please try a couple of times and you decide. See, nothing will succeed if it is forced from above. I very strongly believe that. I believe in what I call participatory management, not management from the top. An order issued by the dean of a medical college asking the 180 assistant professors and associate professors and postgraduates to adopt telemedicine will never take off. So my humble request is, please try it. Now, again, for this to be tried, one topic which you did not cover, which if you don't mind, I would like to introduce, is training, retraining, untraining, if you want to call it. It is learning, unlearning. You need to unlearn what you learned in the previous era. And I'm very happy that the Telemedicine Society of India has already had courses for several thousand people. Government of India, as part of the regulations, telemedicine practice guidelines, have mentioned that within 3 years, every RMP should get certified. 1.5 years are almost over. So I think it's very essential. And I do hope the National Medical Commission, the erstwhile MCI, will introduce telehealth, at least give 40 hours or 50 hours during the 4-year training program. You need a formal exposure to telemedicine and telehealth. Nobody taught me telemedicine. I learned it myself, but that was 21 years ago. Today, telehealth has become so complex. I won't say complex. It's so much of information. It's like cardiac surgery. You can't become a cardiac surgeon in 3 months. You can't learn how to do telemedicine by switching on your video camera. No way. So you need a formal course, and I entreat everybody to please attend these courses and try it out for a couple of weeks. And if you are not happy, tell us why you are not happy, and we will make you happy.
Thank you so much, Dr. Ganapathy, for sharing your experience and views with us. It was a pleasure talking to you.
Thank you, Rashmi. Thank you very much.